We've had 3 splendid presentations this afternoon, which have set the scene very well indeed for how we work towards embedding those essential principles that need to be embedded if we're going to keep both the patients and the staff safe. There will be someone coming round, by the way, to collect your forms. That is the last time I promise I mention that until we actually come to the denouement. I'll tell you a little horror story just to set the scene and then take questions. A few years ago in Sheffield, you have to train people to be able to do things like take blood and so on. And one of my colleagues told me about a case he was involved with that a medical student had said, would you like to practice taking blood? And the student said, yes, I'd love to. Anyway, as he was standing in front of the patient with the needle and syringe, he accidentally stabbed himself with it. But he hadn't put it in the patient. Unfortunately, he then proceeded to stick it in the patient and take a blood sample. And the patient sat there, I have to say, looking a little incredulous at this. And after the blood had come out, he waited until the blood was out because the guy got and said, what did you just do? And the medical student was entirely nonplussed at this point. And of course, we went into the situation where, what do you do after a needle stick injury? And the medical student was tested. And after his hepatitis C was diagnosed, this led to some considerable difficulties with dealing with the patient. The medical student was indeed hepatitis C positive. He came from part of the world where it was endemic, hadn't been tested beforehand, and as you can probably gather from that story, there were lots of areas where there was considerable room for improvement. I hope we wouldn't do it the same way now, but you never know, and there's always room for improvement. So, do we have any comments from the floor or questions, please? Yes, please.
Thanks very much to all the speakers. Very interesting. I'm just regarding Dr. Pellowe's talk. I've done a lot of hand hygiene observations as part of my work as a research nurse, and in relation to gloves and aprons, I noticed a lot of the time hands were not being washed before acquisition, and there is evidence that glove boxes can become inoculated with all sorts of pathogens, especially as they're so difficult to retrieve. They all stick together, they fall on the floor, and people, almost like a Pavlovian response, put them back in the box. So I think there needs to be an emphasis on proper decontamination, not only after use of protective equipment, but before acquisition. I just wondered what your thoughts on that would be.
Thank you. Yeah, I think that goes back to things being fit for purpose. And just as in the same way you find, aprons often sitting on the side, there is an issue that there's no point using them if they're already contaminated. So yes, I would agree with you. But I think that's where we all have a responsibility, because we're all going to be wearing PPE, and if it's not the right thing for the job, you need to be telling people. I mean, when we wrote the first set of NICE guidelines for the community, I was horrified to discover the GP had never once thought, on the committee, had never once thought of taking any hand hygiene equipment with him to do a visit. And I didn't like to ask him, how did he wash his hands if he got to a place? And this was in Liverpool. What happens when you get to a home where you can't wash your hands? I just dreaded to think. But people do need to shout out if they find things are not right. And if the gloves are, and I know exactly what you mean about pulling gloves out of boxes. If they're not right for the area, then you must tell procurement that they're not right and say this has got to be changed. Goes back to standards, doesn't it?
Yes. Can I pick up on the point about aprons? Aprons don't fit very well. The NHS buys the cheapest possible apron that's provided in bulk. For those who are less bulky than I am, the front will come down here and the bottom of it will be touching their toes. But it doesn't cover the shoulders and it doesn't cover the arms. I've used those same white plastic disposable aprons in the waste sector when lads and lassies are handling large volumes of clinical waste, dripping in blood and heaven knows what else. And for one very forward-thinking company, they offered plastic aprons. So we sprayed these aprons after they'd taken them off very carefully using luminol. And they were splattered almost like Swiss cheese with droplets of blood showing bright blue illumination. But most of it you could see. But then we got them to stand against the wall and sprayed them from head to toe, or from chin to toe. And their shoulders were covered, the nape of their neck was covered with blood splashes, their arms were covered, and the sides of their thighs and down at their shins was all covered with splashes.
What had they
So
been doing?
maybe instead of aprons, we need disposable gowns that have a better cover.
Well, we do have gowns, and they are available. It's a question of persuading people whether they need to wear them or not.
It just sounds like they've been very energetic, though, to get it on the side of their thighs. You do wonder.
Well,
about,
carrying 2 or 4 bags out of the hospital environment or from the waste yard into a vehicle.
yeah, it gets on your thighs.
They're on their hands, they're throwing bags into large containers, they're tipping from one container to another, and we see how heavily bloodstained they can be. Lots of splash inoculation.
A very good excuse for looking at people's thighs, then. Thank you very much.
What Dr. Pellowe was saying about the risk assessment, it's really relevant because I come from a theatre environment, and one of the surgeons' favourite practices was to take a green apron off a roll on the wall and put it under their fluid repellent gowns, which are supposed to be sterile. And when you ask them, why are you doing that? Because when I get strike through, but they're not thinking through the process, because if they get strike through, they're immediately going to infect their patients. And it was a practice I used to bang my head against a brick wall about. So what advice would you give for that? I mean, just remove them completely.
Well, that's one option, yes. I think the thing is, actually, I think we've bandied around risk assessment as a phrase without ever actually asking people, how do you do one? And I think that ought to be part of audit. Rather than, just counting, the number of times people do this, actually ask them, how would you do a risk assessment? And I think we'd be quite surprised as to what people came up with.
Absolutely. Could I just mention the word audit came up there? I mean, it's always worth having that mantra at the back of your mind that research tells us what we're supposed to be doing, audit tells us if we're doing it. And that's something everybody in this room, I'm sure, adheres to and knows, but it's so obvious that we should have it tattooed on the back of our hand. There's a question over here. Yes, thank you.
Hello. This is a question to Dr. Pellowe. It's regarding the mask. The surgical mask, obviously, we know about is next to useless. But you mentioned something about FFP3 and the need for fit testing. How often does fit testing needs to be done? The reason is I'm actually working on a bulletin for MERS coronavirus. And when I look at the various sites, the WHO for the African continent, they're saying surgical masks. For the European report, the 7th update mentions obviously FFP3, so does UK. Then when I look at CDC Atlanta, they're using N95, which is equivalent to FFP2. So when you think about the last time we actually fit tested was pandemic flu. So that's well over 4 years ago. People get thinner, fatter, hair growth. So you mentioned that if it doesn't fit, it's next to useless. So what would be the best to use if you do not have time now to train everybody up fit testing for FFP3? Would FFP2 N95 be adequate?
Ooh, I think you put me on the spot here. I would say, in practice, I think you should do FFP3 whenever you need, because it's not as if you're using them every week. But when you start to use them, then you need to go up and make sure. I mean, it is a role for occupational health. It's often left to the infection control team to do, but in fact it's an occupational health issue that as soon as they start needing FP3, then there should be a complete thing to actually check everybody at that time. Because I think doing it in advance, people forget. And even when we're using them in areas where we use them often, as I say, you often find people, say, oh, these last for 8 hours, therefore I'll, shove it in my pocket and forget about it until I need it the next time round. So I think there's often, it's at the time when they're most needed is the time that you should check the testing and remind people about how to use them correctly.
I do understand what you're saying about fit testing when you need it. However, in terms of service delivery, you can't just stop everything just to fit test everybody when you need it. There needs to be a planned program in place. So what I'm asking is for those, because it has to be a rollout, because you can't pull all your staff out to fit test them. So say, for instance, tomorrow we need to actually deal with this. if we don't actually have FFP3 fit-tested personnel to deal with any kind of sort of situation that requires FFP3, would FFP2 be adequate? Because that doesn't need fit testing, does it?
I don't know. I've not had any experience with FP2, so I couldn't comment.
Okay.
We have a comment over there.
Dawn Moss from Stoke-on-Trent. I can answer your question for you. I work in critical care, and we had flu pandemic on critical care. The standard from the Department of Health says that mass fit testing should be conducted for every person that works on that area with those risks. And it should be conducted every 2 years unless somebody has significant weight or loss gain. Then what you need to do then is you need to keep a record of that testing. But there is lots of masks out there. They are very expensive, some of them, but the expensive ones are the better masks. FFP3 masks, you use them for different types of infection. FFP2, again, it's a type of infection that you're dealing with. So that information is actually on the government website.
Thank you.
Thank you very much indeed. Another comment.
Thank you very much. I'm Chris Fuller from UCL. Mine's a hand hygiene question. Louise was talking about the successes of the Clean Your Hands campaign and the fact that now it's defunct. I just wondered what the panel and perhaps members of the audience thinks happened to hand hygiene now. Have we lost all of the gains that we got from the campaign or no?
Thanks, Chris. And I think the research from your group has been pivotal in perhaps the way we need to go forward. As you know, the Hand Hygiene Alliance has been trying to sustain the momentum, if you like, of the Clean Your Hands campaign, but it is very difficult. And as I said earlier, I think that possibly one way forward is to look at some sort of audit process which is agreed, perhaps in the same way, you know, that surgical site surveillance is agreed, that the actual process is going to be common to us all, because it is grieving, isn't it, to sort of see 100% hand hygiene in our various audits and know that actually that's not the case. But I also think that we need to just incorporate this fundamental standard within the patient safety agenda as just part of the process.
Yes, I think that's absolutely vital. Can I ask, are there any patients or lay people within the audience who'd like to make a comment? In particular, Dr. Teare presented a slide with the evidence, was it yourself? That the member of the public had observed a member of staff failing to engage in the correct process, and it clearly wasn't something you needed training to do, because somebody who had no training whatsoever recognised that it was not the way to take things forward. We have a hand up over there. Thank you, sir.
Yeah, my 92-year-old father was in hospital 3 years ago with an E. coli infection, and we observed a nurse that came in to actually change his catheter. And she came in, washed her hands, fine. She gelled them, fine. And then she went to put a pair of gloves on, pulled one glove out of the box to put it on, and then got called by another patient. So she put the glove back in the box and walked away. Now, I suddenly picked the box up, went to the nurse's station and told the sister on duty that that box must be disposed of, because we don't know if it's contaminated the rest of the gloves. But she'd done everything right, but for a moment's lapse, she put other patients at risk. Hand hygiene is about what Aristotle said. We are what we repeatedly do. Excellence is not an act, it's a habit.
Thank you, sir. You're from Action on MRSA, and you're absolutely right to bring that up. I hope you all agree that we've had a splendid day today. We've had an excellent group of speakers, myself excluded, and I personally have learned a great deal today. But more important than people talking to you has been the dialogue and the discussion. The sharing of ideas, concepts, experience is everything in healthcare, in medicine, in nursing. you're really nobody if you can't talk to your colleagues about what you've done, what's there to be learnt, and it's by the pooling of that experience that we all learn. So I consider it a privilege to be here with you today. So travel home safely and hope to see you at the next one. Thank you very much.